to do this, how I get to do this, but I got to do it for prologues. I get to do it for our residents. And so it's a topic that I do lecture on frequently, but unfortunately I have to change my lectures each time I give it for my audience. Next slide. So you see a cartoon of an adult hemoglobin. So there's two chains of alpha hemoglobin, and those are the red. And there's two chains of beta hemoglobin, and those are the blue. And the green is the iron that is associated with hemoglobin, and it's where the oxygen binds to the hemoglobin molecule to be carried throughout the body. So when we look at hemoglobinopathies, the very first thing that we start with is a complete blood count. Often you will see a hemoglobin hematocrit, and they can be totally normal, and the patient can still have a hemoglobinopathy. The key to your complete blood count is your mean corpuscle volume. Basically, that is the size of the red blood cell. And I actually have this backwards. Microcytic anemia is less than 80, and that's associated with iron deficiency anemia, which is very common in pregnancy, or hemoglobinopathies. Macrocytic anemia is the red blood cells are larger, and it's associated with B12 or folic acid deficiency. And this is you often see this in older individuals who have and alcoholics. So the microcytic anemia, a hemoglobinopathy can have normocytic anemia or normocytic blood counts, or it can be microcytic. Next slide, please. So when we look at this CBC, the other thing that we look at is the hemoglobin electrophoresis. So a hemoglobin electrophoresis is reported as hemoglobin A1, hemoglobin A2, or hemoglobin F. And on a normal hemoglobin electrophoresis, F is usually less than 1%, A2 is less than 3.5%, and A1 is 96 to 97%. And that is your normal hemoglobin electrophoresis. So sickle decks, can I just tell you that I see sickle decks ordered on individuals all of the time, okay? It is a useless test, and the regional educators, I wish you would educate your offices that it's a useless test and should not reassure them at all. It's actually used in emergency rooms, especially like in the mountains and stuff, when people come in with symptoms that doesn't have sickle cell disease, and they can get a quick answer. It's quicker than a hemoglobin electrophoresis to see if a patient has sickle cell trait. Now, a sickle dex will only tell you if there is a trait of S hemoglobin S. It does not tell you anything else about the individual. And in fact, they could have sickle cell disease and have SC disease or sickle beta thal, and it may not be positive. So please do not waste money on sickle dex. Go straight for the CBC and hemoglobin electrophoresis. Next slide. So sickle cell is a defect in the beta hemoglobin. It's literally a point mutation in the DNA. And so the DNA is, transcribed to RNA, and RNA then makes the protein. So the one change in a mutation goes from a GAG in the RNA to GUG. And just that one mutation, you get glutamic acid in a normal protein, normal hemoglobin. And with that change, you get valine, okay? That's not important, but that one molecule, that 1 point mutation causes the hemoglobin, a normal hemoglobin, to be clumped, and it causes patients with sickle cell disease to have a sickle-shaped red blood cell. Now, in sickle cell disease, sickle cell traits, and sometimes in disease, the reticulocytes are increased, and therefore your MCV can be totally normal. And so you must remember this. Next slide, please. So there are basically 3 types of sickle cell disease. There's some very other rare ones, but if I've never seen them in 30 years, I don't think they're important to present in a slide. But there are 3 types. There's SS disease. That means that everybody has the same point mutation that I just showed you. And so they have hemoglobin S instead of hemoglobin A1. And the amount of S on a hemoglobin electrophoresis will tell you if this individual has disease or a trait. The disease usually has 60 to 70% of SS, and the trait usually has 30 to 40%. But the other thing that you can use is their history, because patients with trait do not usually have a crisis, a sickle crisis, unless there is stress of some sort. Like, for example, you can, if you go to Park City, Utah skiing, you can actually have a sickle cell crisis because if you have trait, because the oxygen tension is so much lower, because Park City's almost at 12,000 feet. Now, hemoglobin SS is the worst type of sickle cell disease, and it's the worst actor during pregnancy. The next type is SC, hemoglobin SC. So you will have hemoglobin S on your electrophoresis and hemoglobin C. And basically, the only difference between S and C is 1 amino acid. C is also a point mutation. Instead of going to valine, it goes to leucine. And SC disease is not as, they don't tend to get as many cycles as SS disease. And then the next type of sickle cell disease is sickle beta thal. And what you will see on the sickle dex, not sickle dex, but the hemoglobin electrophoresis, is you will see hemoglobin S, then you will see A2 increased and F increased. And there is no way that you pick up sickle beta thal on a sickle dex, okay? And you don't necessarily pick it S, you don't pick up SC disease on a sickle dex. So I've already told you about what you see on the hemoglobin electrophoresis. So we'll go to the next slide, Rachel. So the next thing I'll talk about is beta thalassemia, because it is actually the next most common hemoglobinopathy. Now, beta thalassemia can be seen in African, Asian, Greeks, Italian, and Middle Eastern individuals. It is most commonly associated with the countries around the Mediterranean. Now, beta thalassemia, they all have low MCVs, okay? They may not have anemia. They might have a hemoglobin of 12.5 and a hematocrit of 35, but the MCV will be 79, and that is your trigger to order a hemoglobin electrophoresis. Again, the hemoglobin electrophoresis shows less hemoglobin A1, increased hemoglobin A2, and increased F. A2 is usually around 5%, and F is usually or greater, and F is usually around 2 to 3 percent. Now, there are 3 types of beta thalassemia. There is a minor, where they only have one mutation in the 4 genes of the beta chain. And these people are totally asymptomatic. Then there is the intermediate type, and it actually has 2 genes that's abnormal and 2 genes that's normal, but it makes enough, usually enough beta chain to be asymptomatic or rarely require a transfusion. You either intermediate is basically has a range of findings. Again, it's usually on the low end, no symptoms or an occasional transfusion, but it can also be transfusion dependent. Now, hemoglobin beta thal can also be beta thal major, and this is known as Cooley's anemia, and these individuals are transfusion dependent. In the last few years, it has been recommended that we go from minor, intermediate, and major to either transfusion independent or transfusion dependent. Next slide. So this is, again, just a review. That beta thalassemia trait is just a 1 gene mutation. It's usually asymptomatic. Beta thalassemia intermediate is a 2 gene defect, and it has mild to moderate decreased beta globin synthesis, and the symptoms of it is variable. beta thalassemia major, there's 2 gene defects. There's a severe decrease in beta globin synthesis, and these individuals have a lifelong requirement for blood transfusions. Next slide. Now, alpha thalassemia is actually, I usually think of alpha thalassemia from Southeast Asia, but it can be from Africa, the Middle East, India, or Southern China. Now, they all had low MCVs, and the kicker with alpha thalassemia, it will have a normal sickle dex and it will have a normal hemoglobin electrophoresis. The diagnosis of alpha thalassemia is made by DNA testing. Next slide. So with alpha thalassemia, there's basically 4 types of it. Alpha thalassemia, a silent carrier, there's only 1 gene missing, and usually we know nothing about these individuals. The alpha thal carrier has 2 genes that's missing, and they have a low MCV, and their hemoglobin can be very normal. Hemoglobin H is 3 genes are missing, and alpha thalassemia major, all 4 genes are missing, and this is incompatible with life. It actually presents as what we call hemoglobin Bart's disease, and hemoglobin Bart's disease usually shows up somewhere in the mid-2nd trimester as fetal hydrops. Next slide. Now, when you send a patient to a genetic counselor, they're going to talk with you in that letter about cis and trans mutations. So on the first line, the 4 black boxes represent 4 functional genes. You got 2 on each chromosome, okay? With a silent alpha thal mutation, you have 1 gene that's missing and 3 that is normal. So with the alpha thalassemia trait, you have 2 abnormal genes and 2 normal genes. So a trans mutation is on 1 chromosome, there's a normal gene and an abnormal gene. And on the other chromosome, it's matched. There's 1 normal gene and there's 1 abnormal gene. Whereas the cis mutation is there's 2 normal genes on 1 chromosome and there's 2 abnormal genes on 1 chromosome. Now, why do we care if there's a cis or a trans mutation? You cannot get hemoglobin Bart's with a trans mutation, okay? You can only get it with a cis mutation because the individual, the baby, has to inherit 1 gene that has no normal alpha genes and has to get the other gene from the father who has a chromosome with no normal alpha genes. And so this is what gives you no functional alpha genes and is lethal. You will see in our population, could you go back, Rachel? In our population, sometimes we do not recommend, so So when you order a DNA test for alpha thalassemia, it'll come back and say they have the mutation or not. But it doesn't tell you if it's a cis or trans mutation. Now, most of the time, we do not order an additional test to say if it's trans or cis. And the reason we don't do that is African Americans in our country almost always have the trans mutation, and none of them have the cis mutation. But if this individual is from Southeast Asia, Philippines, we will order the genetic test to tell us if this is a cis or a trans mutation, especially if the father of the baby is not available. So that is why it's important to remember that. Next slide. So anemia is very common in pregnancy. And most of the time it's iron deficient, especially in multiparous patients. And iron deficient anemia, it actually is associated with a low MCV. Whereas beta thal and alpha thal are also associated with a low MCV. The red blood cell distribution, and it's the RBCW or RBW reported on our CBC, is usually high in iron deficient anemia and is usually normal in beta thal and alpha thal. And so that can give you a clue if some individual has iron deficient anemia versus beta thalassemia. And if I see the high red blood cell width, what I'll do, especially if it's not in an ethnic group that's associated with hemoglobinopathies, I will substitute them with iron. If their MCV comes up normal, then I do not do a hemoglobin electrophoresis. But if it doesn't, then I do all the iron studies and an electrophoresis. Now, ferritin is low in iron deficiency anemia and normal in beta thalassemia and alpha thalassemia. And again, the hemoglobin electrophoresis is normal in iron deficient anemia and normal in alpha thalassemia. But in alpha thalassemia, you do the DNA testing, and in beta thalassemia, the beta hemoglobin electrophoresis will be abnormal. Now, I don't know if y'all been reading any ACOG stuff, but working with ACOG, they actually have a group now to tell us what pronouns to use. We use patient instead of pregnant woman. I mean, because we're supposed to be, quote, politically correct. Now, I argued on the hemoglobinopathies that this is truly ethnic / racial disease, and we have to keep race in there because in this country, 10% of African Americans actually have a hemoglobinopathy. And therefore, when I see an African American, if they have not had a hemoglobin electrophoresis, I order one along with a CBC. And I'll do the same for Southeast Asians. And, you know, if you're like me and you're white, you know, I'm a mutt. I came from all over the place. I have no idea where I came from, but I might have a little bit of Mediterranean blood in me, or, I might have sickle cell trait. But if I am, if I have a low MCV, and I'm going to look for iron deficiency anemia. And if I don't have iron deficiency anemia, I'm going to send off a hemoglobin electrophoresis. And to me, this has, to me, this is not discriminatory. It's just what it is. And so their debate now at ACOG is whether or not we have to send off a hemoglobin electrophoresis on everybody. But I just think it's a waste of money to do so. And that's my opinion, and I'm sorry if it offends anybody. All right.
Thank you so much, Dr. Johnson. Before we open it up to questions and discussion, just a reminder, we will be back on November 17th, and we will be discussing thyroid disease. I want to invite everyone at this time, if you can, to share your screen. It helps us to create a sense of community, and we know it is the lunch hour, and that's fine. Please feel free to use the chat feature, and I will make sure I'm monitoring that, and we'll share any questions or comments aloud. Okay, thank you.